This video will be covering causes of toeing in and toeing out, some specific causes of toeing in and toeing out, starting up at the hip and running down through the feet. To get things started, just realize toeing in is going to be a very common rotational deformity, especially in growing children. We'll look at a couple of those causes of that, and as people grow older, they tend to grow out of that toeing in, and we'll look at a few of those reasons why. So first I wanted to start with tibial torsion. Tibial torsion is exactly as the name sounds, where that tibia can rotate through the shaft, resulting in some toeing in or some toeing out, depending on which way that shaft of the tibia has rotated. So you can see in these images here some toeing in as a result of this tibial torsion, where you would visualize this person from the rear or from posterior view, and you would see some of these toes, some extra toes, because that tibia has rotated in. However, you can also have instances where it rotates out, in which case you would see more of the outer toes from a postural assessment. We are going to move into femoral anteversion and just very briefly retroversion. Anteversion of the two is the one that causes the toeing in. So I want to go to this image actually, just to help you. Hopefully this can help you conceptualize anteversion and retroversion a little bit better. So what we're doing here, we're actually taking the angle between two different places in the femur. So you can see this line here is running through the head and the neck of the femur. So here. And this line here is going to be, imagine this femur sitting on top of a table. This line here is going to just be where those condyles would sit on top of the table. So this angle that the head and the neck will make with this flat surface here is going to be called our femoral torsion angle, or our amount of anteversion or retroversion. So hopefully that helps you visualize a little bit what's going on here. I'll fast forward just a little bit. So I'll make this bigger so you can see it. So the normal degrees of anteversion here are going to be 10 to 15. And we actually have a clinical test that we'll do here in class that will help us see this angle. If you have someone that has femoral anteversion here, the angle is going to be greater than 15 degrees. Going to be greater than 15 degrees. And you can see this green femur. This is what it's going to look like here. So you can imagine if you slide this femoral head into the acetabulum, that's going to result in this angle here turning in, resulting in femoral anteversion. Just as you can have anteversion, you can certainly have retroversion. Less than 10 degrees, you're going to have this type of a relationship. You can imagine, again, moving this red femur up into the acetabulum, and what's that going to do to this angle down here? And it will result in more of a toeing out scenario. So the femoral anteversion will lead to that toeing in. Femoral retroversion will lead to that toeing out. I'm going to go ahead and come back here to our slide. So you can see on this femoral anteversion again, we're going to be pushing this distal femur in, resulting in a toeing in scenario. Here's another image of this here, where they're actually taking the measure of the femoral head and the femoral neck in relation to that femur sitting on top of a table. This gives us a little bit of the progression and why that toeing in is going to be common as kids are young, and as they age, how they're going to age out of that toeing in. So femoral rotation decreases with age. So remember, femoral anteversion is when this angle is greater than 10 to 15 degrees is what that video said. So at 1 year old, maybe they'll have 39, 40, 30 degrees as they're getting older. And you can see over time, the amount of anteversion decrease, so the chances of toeing in will also decrease. Going to go ahead and move into some of the causes. Lots of different causes. You could have congenital decisions. You could again have some muscular imbalances. Maybe you have some spastic adductors which are pulling you in, or maybe you have some spastic hip abductors which are pulling you out to go into more of a toeing out position. You can see down here twice as common in girls. We'll talk about this W sitting here in just a couple slides. So there's many causes of anteversion. And some of them you can't escape, they come from genetics. Others can be worked on through types of rehabilitation, and some come just from a postural type of instance. So I'm going to go ahead and move further down. So we're going to talk about this W sitting here, and then we'll come back to that Craig's test. So W sitting here increases the chances of having femoral anteversion later into life. So I want you to think about this position here. So as a young child, my daughter actually loves to sit in this W sitting position. As a young child, these kids love this. They're flexible enough to achieve this position. And you can see how when a child sits in this W position, it gives them a wide base of support so they're less likely to fall over. And hopefully you can appreciate that. But now I want you to go ahead and just imagine for a second inside, imagine that femur. Imagine the head and the neck of the femur, and then the distal end of the femur, and what you're actually doing to that femur if you sit in this position over and over and over constantly throughout your life, and especially through your growing years. You can actually increase the chances of femoral anteversion just by sitting like this long enough. And we talked about that a little bit in our postural unit. If you have someone that sits over and over and over like this, it can actually become a chronic thing where their body develops like that, according to Wolff's law, thereby increasing their chances of anteversion. So this slide's covering Craig's test. I've got a short video here that we're going to look at here, and I'll kind of talk us through this as we go through. Fast forward just a little bit. So what you're going to do, you'll have the person, this is a test testing for the amount of femoral anteversion that a person has. So you're going to have the person lay on their stomach on the table with their knee bent to a 90-degree angle. And then what you're going to be palpating for is the greater trochanter of the femur. Once you've palpated that greater trochanter of the femur, you're just going to move their foot in and out. And what you're feeling for is the angle of greatest prominence at the greater trochanter. So as you move through, you're going to feel the greatest prominence. And fast forward a little bit here. So this image here, so then you can go ahead and measure this angle. So the angle from here up through the femur, and hopefully that angle is somewhere between, 8 and 15 degrees is probably going to be pretty normal for our femoral anteversion. If you have an angle that's greater than that 15, so you're going to push them over, then that person would be experiencing anteversion. If they're less than that 10, 8, then they're going to be in femoral retroversion. So that's Craig's test assessing for femoral anteversion and retroversion. You can imagine that femoral anteversion is going to often be associated with genu valgum, and you just need to be have a thorough evaluation, which is going to give you an indication of what is actually happening. And then the last one we'll just cover briefly, just in a couple slides here. Metatarsus adductus. You can imagine how this will relate to toeing in posture. I think we actually talked about this briefly in I think we called it forefoot adductus in our foot and ankle unit. And all that's going to be happening is those metatarsals are going to be pushing in, resulting in those toes moving a little bit more in. And that finishes this video covering largely femoral anteversion and retroversion, but as well as tibial torsion, and just a reminder on this metatarsus adductus.